This training presentation introduces a clinical care pathway for urinary tract infections, UTIs, to dip or not to dip. The aim of this pathway is to improve the quality of care for older people living in residential aged care services with suspected UTIs. It focuses on how you, as people working in residential aged care, can improve the diagnosis and the management of suspected UTIs and can also help to prevent UTIs in your residence. Let's start with a quick quiz to get you thinking about UTIs. Who is more likely to experience a UTI? The answer is women. Women have a shorter urethra than men. The urethra is the tube that connects the bladder to the outside. This makes it easier for bacteria which live inside the bowel to get into the bladder. Another question. What percentage of aged care residents are prescribed an antibiotic for conditions related to the urinary tract? The answer depends on the type of aged care service. There is wide variation in practice. However, a national audit of Australian aged care services found that at any point in time, 1 in 4 residents will be prescribed an antibiotic for urinary tract-related conditions. Antibiotics have saved millions of lives. However, they are often used when they are not needed. Because of antibiotic overuse, we are now seeing antimicrobial resistance in bacteria, resulting in infections that antibiotics cannot treat effectively. These resistant bacteria are also known as superbugs. The more antibiotics we use, and we use a lot, the faster resistance develops in bacteria. Antimicrobial resistance is one of the biggest threats to human health today and can mean certain antibiotics may not work in the future. We have higher rates of antibiotic-resistant bacteria, such as golden staph and E. coli, a common cause of UTI, in aged care services than in the wider community. We know that suspected UTIs are a common reason for antibiotic prescriptions for older people, especially in aged care services. To dip or not to dip was a project that introduced clinical pathways in England's aged care homes to reduce unnecessary antibiotic prescribing for urinary tract conditions. This pathway more than halved the number of antibiotic prescriptions for UTI. It also further reduced antibiotic use for the prevention of UTIs. Quality improvement projects, such as To Dip or Not to Dip, show that antibiotic use may be safely reduced by changing the way that UTIs are diagnosed. In particular, when deciding to undertake urine dipstick testing or not. You may have guessed that the To Dip or Not to Dip pathway relates to urine dipsticks. But first, let's recap what a UTI is. The urinary tract consists of the kidneys, which filter the blood and produce urine, the ureters, which are the tubes connecting the kidneys to the bladder, where the urine is stored, and the urethra, which is the tube through which urine leaves the body. Bacteria normally live in the bowel and on the skin, but can enter the bladder by travelling up the urethra into the bladder. They can then grow and multiply, and may cause symptoms of an infection. We will discuss the symptoms and signs of UTIs in older people shortly. Bacteria in the urine does not always mean an infection is present. In older people, bacteria often live harmlessly in the bladder without causing any problems. This is not an infection, as the bacteria are not causing any harm to the person, and treating with antibiotics does not reduce the likelihood of future infections. This is called asymptomatic bacteriuria. So what proportion of older people does this affect? Studies have shown that up to 40% of older men, 50% of older women, and 100% of people with long-term urinary catheters have bacteria in their urine without any signs or symptoms of infection. Asymptomatic bacteriuria or ASB in older people or those with catheters does not require treatment with antibiotics. And in fact, antibiotics may cause unintended harmful side effects. When diagnosing UTIs in older people, dipsticks are not useful. Why is this? Dipsticks cannot tell the difference between bacteria that are causing an acute infection and bacteria that are living in the urine harmlessly. The urine dipstick will most likely be positive for nitrites, a chemical most bacteria make in the urine, and leukocyte esterase, which shows the presence of white blood cells. But these markers do not tell us if there is just ASB, which does not need treatment, or a urinary tract infection that requires antibiotics. To diagnose a UTI, a clinical assessment of symptoms and signs is needed, and Australian best practice guidelines recommend this approach. But is there any harm in dipstick testing? It is very difficult to ignore a positive result, even though it may be just ASB. Relying on the urine dipstick result in this setting may result in the real diagnosis being missed. It can also trigger antibiotics being prescribed unnecessarily. Antibiotics are powerful and precious drugs. When antibiotics are needed, their benefits outweigh the risks of side effects and antibiotic resistance. When antibiotics aren't needed, they won't help, and the side effects could still cause harm and contribute to antibiotic resistance. Antibiotic side effects are common, occurring in 1 in 3 people, and older people are at increased risk. Antibiotics can cause Clostridioides difficile, also known as C. diff, infection, a gastrointestinal illness that can be life-threatening. It is also clear that antibiotics can disrupt the balance of the body's healthy bacteria and increase the risk of carrying a resistant bacteria. That means antibiotics should only be prescribed when there is clear evidence of an infection. So the key message is, urine dipsticks should not be used to diagnose UTI. Rather, symptoms and signs should. An Australian clinical pathway has been developed to help teams in aged care services look after residents with UTIs using current best practice guidelines. This clinical pathway supports you as aged care service staff to recognise and record the signs and symptoms of a UTI and communicate these clearly with the GP and your team. It also guides you on when to dip or not to dip. When assessing a resident, always consider serious infections first, especially sepsis or pyelonephritis. Sepsis is a potentially life-threatening condition where infection enters the bloodstream, leading to shock. Pyelonephritis is a UTI affecting the kidneys, which may lead to sepsis. Always consider whether any signs of sepsis are present and use your locally approved sepsis tool or policy. If the resident is very unwell and you would usually get urgent help, then of course do this as you normally would. If there is no suspicion of sepsis or pyelonephritis, then you can use the clinical pathway to assess for signs and symptoms of a UTI. There are 2 pathways to use, one for residents without catheters and another for residents with urinary catheters. Let's focus on the clinical pathway for residents without catheters. The pathway has an assessment section where you can tick off symptoms or signs that are present in your resident that are new or worse than usual. Symptoms or signs of a UTI include pain or burning on passing urine, dysuria, fever or higher temperature than usual, new or worse confusion or agitation, urinary frequency, urinary urgency, new or worse urinary incontinence, flank pain where the kidneys are, low abdominal pain where the bladder is, or visible blood in the urine. Personal care assistants and nurses can work together to complete this first section. The second section is completed by the nurse. The clinical pathway allows nurses to interpret the initial observations and provides a guide on next steps. 1. A UTI is possible or likely and you should investigate and manage as such. Dipstick testing is usually unhelpful, but a urine culture should be sent if a UTI is possible and you are considering starting antibiotics. The urine culture is used to grow bacteria in the laboratory and tested against a number of antibiotics. The result can help the antibiotic prescriber choose the best and safest antibiotic to treat the resident. Or 2, a UTI is less likely and other conditions should be carefully considered. Urine dipstick testing should not be performed unless requested by a resident's GP. Or 3, a UTI is unlikely. There is a separate pathway to use for residents with catheters. It is important to use the correct pathway as the section on symptoms and signs is different. Smelly or dark urine are not signs of a UTI. Do not investigate or treat for UTI if these are the only symptoms. Smelly or dark urine can be related to dehydration or certain medications. Urine can be stronger smelling in the morning and when continence aids are due to be changed. The next section of the pathway is the action section, which nurses use to capture actions undertaken. Here is an opportunity for you to practice filling in the clinical pathway using these case details. Ask yourself, what boxes would you tick? What actions would need to be taken? Why will dipstick testing not help? Pause the video here for a moment while you fill in the form. Let's check how you went. Firstly, no dipstick. Are the resident's details filled in? She is not catheterised, so use this form. You should have ticks for fever and new or worsening incontinence. A UTI is possible, and so action should be taken to contact the doctor and obtain a urine sample where possible. The form should be filed in the resident's notes as a permanent record. We also suggest you assess her hydration status to check if she is dehydrated. When it comes to UTIs, hydration is a very important part of treatment and prevention. Why do older people become dehydrated? Memory impairment means they may forget to drink. They may not be able to communicate their needs clearly. Certain medications may contribute to fluid loss. Living in a warm environment means they lose more water. If they are feeling unwell, they may not feel like drinking. All of these put a strain on the kidneys, meaning less urine is produced. Older people are also at higher risk of UTIs as they tend to spend longer periods sitting or lying down, so urine stays in the bladder for longer. Dehydration also causes constipation, leading to incomplete bladder emptying. If harmful bacteria enter the bladder and are not flushed out properly, they may multiply to cause an infection. You can recognise the signs of dehydration in your residents by taking a top-to-toe approach. Headache, tiredness, a dry mouth or tongue, feeling of thirst, cool hands or feet, urinating less than 4 times a day, smelly or dark urine, low volume urine in catheter bag. What can you do to prevent dehydration? Residents should drink between 1 and 2 litres of fluid per day. This equates to around 4 to 8 glasses or cups. If a resident is on a fluid restriction, then follow the advice of the GP on the volume of fluids they should have, but notify the GP if the resident seems dehydrated. Take a moment to think about how much your residents have to drink in a day, and not just how many drinks they are offered. This will give you a better idea of how much your residents are actually consuming. Regular bladder emptying is key to preventing UTIs, so help residents to the toilet at regular intervals throughout the day, especially after a long period of sitting or lying down. Seek advice quickly if a resident becomes constipated, and if there are particular continence issues, contact a continence specialist for advice. Having watched this video, we hope that you feel more confident in recognising and managing UTIs in older people, in preventing dehydration, and in understanding the importance of using antibiotics carefully and safely. Remember, urine dipstick testing should not be used to diagnose UTIs because they pick up asymptomatic bacteriuria. Use symptoms and signs to diagnose UTIs. We have now discussed UTIs, how they occur and how bacteria in the urine does not always mean an infection is present, how to use the to dip or not to dip clinical pathway for suspected UTIs in older people, and the importance of adequate hydration. The Aged Care Quality and Safety Commission has a brochure, Do You Need Antibiotics?, that you can use to answer frequently asked questions from residents and their families. It includes information on conditions where antibiotics are needed and conditions where antibiotics are not needed, including asymptomatic bacteriuria. More information about to dip or not to dip and other antimicrobial stewardship resources are available on the Aged Care Quality and Safety Commission website.